I'm really glad that you could join us this evening. The session is about helping you feel more confident and informed when it comes to staying active with cardiomyopathy, whether you're just beginning to exercise again or you're already have been or you're new to this journey. Hopefully, you will learn some information as what Jane was mentioning earlier to go back to your team and ask them maybe more specific questions around exercise with the new level of knowledge that you might have gained from tonight's session. Have to click something else. Okay, so this is just a little bit about me. Sorry, just doing something here. Yes. So I'm a clinical exercise physiologist. I'm working in the NHS for over nearly 10 years, and I'm working with clinical patients for a little bit longer than that. My and I'm in Imperial NHS in London. I'm studying an MSc in sports cardiology. My background is in sports science, and I've talked to over quite a number of cardiomyopathy groups, over 10 across England, Scotland, Wales, Northern Ireland, and also in my cardiac rehab, which I'll discuss a little bit later. If you don't know what that is, I regularly deal with cardiomyopathy patients, be it ARVC, HCM, DCM, and I regularly kind of have conversations with them about kind of intervening with exercise and using that to kind of help their recovery. The presentation today then is kind of based on the conversations that I might have with those patients, the questions they may ask me, as well as some of the questions that may have asked in relation to when I was doing the cardiomyopathy support groups and the questions they may ask me as well at that point. So being diagnosed with cardiomyopathy doesn't mean the end of your physical activity. It just means redefining how you move, and that would be my key aim today. Exercise becomes more about self-care and sustainability, and will help you explore ways of moving forward while respecting your condition and tuning into your body's signals, like kind of listening to how your body responds to the exercise. These are today's aims. We'll look at how to safely include physical activity into your life after diagnosis. We'll talk through some simple tools, talk about common obstacles, sorry, mispronouncing that, and how to figure out what level of activity feels right with you. Um, it, Everything we cover will be practical, realistic, and based on real life experience and research. And the research is forever evolving with this, which is the limitation sometimes with cardiomyopathy patients when they're dealing with healthcare practitioners. Is sometimes there might be a lack of knowledge from that practitioner, and then sometimes the patient themselves then might feel a bit neglected. Our goal is to provide clear, practical advice that you could use kind of straight away. Will help you learn how to recognize your own limits, know when to push forward, and know when to step back. And it's about building routines and support that building routines that support your heart health and your mental health well-being kind of day by day. And as we're saying at the beginning, I'll take questions at the end, but ultimately, hopefully this is quite informative. So this was a survey that was carried out in with Cardiomyopathy UK among cardiomyopathy patients, and you can see it paints a very clear picture that very few people with cardiomyopathy are being offered tailored rehabilitation. What that means is exercise intervention that is tailored to their kind of diagnosis. Just 12% had cardiac rehab discussed with them. Only 6% saw a dietitian, and 92% said their condition impacted their ability to exercise. And this is why we're seeing, I'm not sure if you would have seen kind of some communications from Cardiomyopathy UK, among other organizations, but we're seeing a growing momentum in the research and the cardiac rehab community to better support people with cardiomyopathy, offering more kind of structured, condition-specific programs are being explored and developed. And I'm involved in some of them as well, and which we'll discuss a bit more at the end. And my role in this is just to, in the interim, while this has been developed, is just to perform some outreach, which is basically talking on webinars, talking to cardiomyopathy support groups, kind of giving information that I've kind of accumulated over the years in working with patients with this condition. Because ultimately what I've seen is as the care that we offer patients in London is not universal, particularly as you get further from London, or if you kind of go into Wales, Scotland, and Northern Ireland, they don't have the same level of care. some of the key terms we'll be looking at today will be these four here. And we'll be looking at them in the sense to from following a diagnosis, generally people's level of activity or exercise may halt. So when we're looking to be active going forward, we want to understand what does that mean. So firstly, physical activity is defined as any bodily movement produced by the skeletal muscles that requires expenditure. So that might be doing some kind of walking around the house, cooking dinner, brushing teeth, standing up. That's physical activity. Exercise is an activity requiring physical effort carried out to sustain or improve health and fitness. This red box is sometimes where people are given limitations, like I was going to the gym, I was doing this level of exercise, and now I can't. So therefore, what can I do? And that's why we need to kind of highlight these four pillars of being physically active, because ultimately, if you're given restrictions around the red one, can we look at the other ones? Sedentary, it just means sitting down and not moving around, basically. It obviously doesn't include when you're sleeping. So that's another thing that we're trying to modify as we move forward, is reducing your sedentary time. And sedentary time generally is defined as when you're sitting down for anywhere longer than maybe an hour or so. So we're trying to um, break up that sedentary time every hour. And flexibility is just about mobility around the joints, um, kind of pain-free movement, might help with your balance, your coordination. So in relation to this, hopefully you're kind of starting to think a bit more broadly now, that when you're being active post-diagnosis, that it's not just exercise we may want you to do going forward, or what you can explore. Can you explore being a bit more physically active, being reducing your sedentary time, or having a bit more flexibility? Just going on to the next slide. And this is where it comes into the FITT principle. So FITT generally means frequency, intensity, time, type. So this is the information you want from your care team, as Jane was mentioning at the beginning. So from your cardiologist, your nursing team, from your cardiac rehab team, with cardiovascular exercise, which is something you're doing for a sustained effort. You're getting your heart rate up potentially. We'll look at that a bit more later. How much, what duration can you do? What frequency? How many days a week? And at what intensity? Low, moderate, hard? How should your breathing be? How should your heart rate be? Strength training. Are you allowed to lift weights? How many reps? How many sets? These are further questions you should be asking. Being physically active. Have you had restrictions around you can go walking, but don't walk for more than half an hour a day, for example? Or I've seen patients who are kind of really into walking and would walk about 4 hours a day, or sorry, not 4 hours a day, but 4 hours maybe once or twice a week. Is that still allowed? Can you do less? What guidelines can you do around that? And then balance and flexibility. Are you allowed to do core work? Can you do yoga, tai chi? So these are questions you need to be asking, because ultimately, as we go along, and what you'll figure out is, unless you ask these specific questions, no one's going to actually tell you. So if you're like, can I do exercise? They're like, oh, I think you should take it easy for the moment. So that might take out the box on the left, cardiovascular exercise, but can you do strength training? Can you do physically active activities around the house? What restriction? What intensity? Can you do yoga, tai chi? So hopefully you're kind of keeping these things in mind. And ultimately what we're trying to do is as well is redefine how you move forward. So this is a kind of something I often see when working with patients. So the challenge is all I know is high intensity exercise. If I can't run, or if I can't use the gym, if I can't swim, then what's the point? I don't feel like myself if I'm not pushing myself. So I've worked with patients previously, and if they don't get that breathless feeling, if they don't feel that I'm working at a hard intensity, then what's the point of exercising? Am I getting any benefits? The truth, which is the point of this whole presentation, is there are many benefits or many paths to improve cardiovascular health, not just intense exercise. Your body may need a different approach, but the benefits remain the same. You're looking to improve your health, heart health, your energy, your strength, your balance. So we're aiming to shift, i.e., a mindset change, to I'm open to learning new ways to move. And instead of saying I need to go back to what I used to do, to change to I want to understand what's safe and effective right now. And then the key thing at the bottom is because health isn't about what you've always done, it's about adapting with the knowledge and confidence. So a lot of times I see patients in the program, they were a gym goer and now they've been told to be given these restrictions and now they haven't a clue what to do. They're lost. So this is where we kind of have that more in-depth conversation with the patients kind of on a one-to-one basis. And in relation to yourself, this is the questions you should be asking yourself, and also you should be asking your team. And if they haven't got the answers for you, they should be redirecting you to someone who can assist you and have these conversations. When we're going back to the exercise in relation to intensity, instead of saying keep it easy, don't overexert yourself, it needs to be a bit more specific. So this scale is called the RPE scale. It's the rate of perceived exertion. Number 6 means no exertion at all. And that's just when you're sitting down, not doing anything. This scale may vary from person to person, but very light or light could just be walking around the house. Although there is some people who've had heart failure and walking around the house could actually class as exercise because they're feeling a little bit breathless when doing that. Somewhat hard might be traditionally it might be a brisk walk where you're kind of getting your heart rate up, your breathing is a little bit heavier, you're starting to feel a bit sweaty. So you got to ask your team or ask yourself on this scale, what intensity do you recommend am I allowed to do? Should I keep it light, fairly light, somewhat hard, etc.? And when you're exercising in or being active in your own terms or throughout the day, you should pay attention to your symptoms as well. If I'm doing some house cleaning, or if I'm kind of going shopping, or if I'm going for a walk, how are you responding in relation to this scale? Are you starting to struggle with it in relation to a somewhat hard? Should you be working at a lighter intensity? When we're structuring exercise as well, it should be structured using these three main components. Um, at the beginning, we kind of engage in kind of a lighter level of exercise where you're kind of preparing your body for the movement you're about to engage in. Some of you might be on medications, which might blunt your heart rate response, which basically means that when you're engaging in activity, you might feel a little bit breathless at the start. That might be because you've just done a little bit too much too soon. So we want to add in that warm up. That's where a conversation with someone like myself or your cardiac rehab team or your specialist nurses can kind of evolve a little bit more on this and how to do that and direct you to resources as well to help offer further guidelines. Main phase is just that's the main component in the middle. It can be steady state, meaning you can be just going for a brisk walk and keeping at a set pace, or you might need to reduce the intensity because you might be feeling a bit tired, you might be coming to a hill or something. And then cool down is just a gradual return to baseline, i.e., you're reducing the intensity. So if you are going for walks at the moment, do you incorporate a bit of a warm up? Do you have a main phase and a bit of a cool down? Things to be asking yourself. And why do we want you exercising? These are the health benefits from exercise, kind of like a magic pill as such. It boosts your mood, helps manage blood pressure, improves heart function, gives you more energy, and we're trying to limit the side effects when it's done right. So with exercise as well, or being physically active, or doing some elements of strength training, or doing elements of your yoga, tai chi, if it's advised and if you can do that, you're trying to look at it in a more holistic way, as opposed to just thinking it as high intensity exercise. I want to get bigger, I want to get faster, I want to get stronger as such, or I want to just change my body image. And then you have to realize as well that exercise is I'm a big advocate of exercise, of course, but it's not the only kind of avenue or support that cardiomyopathy patients need. We also need to look at nutrition. So in relation to that, how if there's emotions around how you're eating, in relation to my food plate, you have your carbohydrates, your fats, your proteins. Are you kind of more binge eating now? Are you more snacking late at night? In relation to kind of cope with some emotions that may have kind of arisen from the diagnosis? How are you managing stress in relation to kind of the diagnosis itself? Is your sleep quality being sacrificed? Have you started or are you smoking? Is that something we can review and look at? There's loads of therapies out there, nicotine replacement therapies, patches. There's smoking cessation specialists who can offer advice and further guidance on that. Alcohol, is this something you can look at in relation to reducing? If you are drinking, how many units are you drinking? The recommendations is less than 14 units a week. Is there any kind of altercations with some of the medications you're taking? If you're looking to help manage your weight, there's a lot of calories in alcohol as well. Also, medication adherence is a big thing as well. I see with patients. You'd be surprised how many patients I've seen and took themselves off of medications just as a trial period, which is not what we recommend at all. And if you have any concerns about the medications that you're on, you should speak to your specialist team or your cardiomyopathy nurses who can offer more advice. But that's the difficulty with medications is they're working, but you don't necessarily see the benefits of them working. They're not always that clear. So then some patients don't like taking medications and they might experiment a bit with it. So try to speak with your team if you're kind of having those concerns. And education and health literacy basically means you're attending this group here today. You're trying to expand your knowledge on a particular topic to create your awareness and to help kind of create your self-efficacy, kind of your belief in oneself to move forward with this condition. And then the psychological benefits to exercise then as well. We're looking at or being physically active, where it helps to reduce feelings of anxiety, depression, which are common in people. It releases endorphins, your body's feel-good chemicals, and gives you a sense of achievement and control. So this is why I'm such an advocate of being active beyond diagnosis with the right guidelines. And if you're not getting the right guidelines, what questions can you ask to get the answers that you want? Some of the barriers I quite often see, which needs to be discussed with your team, is fear of triggering symptoms. So some individuals, because they're given this diagnosis, and now when their heart rate increases, they think something's going to happen, particularly if they've had an ICD. They're worried about triggering that. Just general anxiety as well about the condition, about if their family members see those being active or they're more worried about them now since they have a condition. That's also a barrier. You shouldn't be doing this, you shouldn't be doing that. Loss of identity is another thing I've seen more often than not with patients as well, which I'll talk about later in a case study in more detail. But I've worked with individuals who identified themselves as a runner and a very good runner at that, a very competent runner in relation to a marathon. They would run less than 3 hours, and they would engage in marathons all over Europe and beyond. But following a diagnosis of ARVC, they were told they couldn't engage in that anymore. So ultimately, they felt since they couldn't engage in the running, that took away who they were, which is a really, really challenging thing. So if you do feel like a loss of identity or something's been taken away from you and you're kind of struggling with that aspect, that's another thing you should be looking at and asking for help with. The social withdrawal is another thing I often see with patients. Um, if you were engaged in a particular activity, going back to the running again, that particular individual was engaged in running groups, and now since they're not running, they don't really engage in the running groups anymore. If you were engaged in a swimming activity, you're not really going swimming anymore, or you're not really going to an exercise class. You're losing that kind of social connection that you had with people when you were being active potentially. So that's another thing we need to be kind of be aware of and kind of try to recognize sooner rather than later. And all of this as well results in a lack of confidence. So you start losing the ability or the confidence within yourself to be active or to exercise in a sense. You've been given this diagnosis, so now you just accepted it and you've just kind of reduced, adopted now a more sedentary lifestyle. And of course, it's all overwhelming. Um, Generally, when people have a diagnosis, if you're new to it, there's a lot of tests, lots of medications that you've never been on before. There's lots of appointments that you need to attend, lots of telephone calls. Some of them are it might be a lack of face-to-face appointments as well. It might be just more telephone or just a quick catch-up where you don't really have time to even ask questions. And that's where Cardiomyopathy UK Charity comes in as well. The nurses can, they're there to kind of have those conversations with you and help support you through your journey. These are just some kind of coping strategies to help deal with some of the things we spoke about in the previous slide. If you're not doing it already, could you something you could be aware of, because it all relates to back to being physically active and kind of getting support you need. So first is just kind of acknowledging and validating the fear. So understanding that you are anxious and saying to yourself, I am anxious, I am nervous about this condition, I am worried about having an ICD, I'm worried about it being shocked, I'm worried about exercise triggering it, I'm worried about doing more damage to my heart when I exercise. Understanding that or acknowledging that is a great first step, because then you can start seeking answers or seeking support to help overcome that. Um, Start small and celebrate wins. So even, if you did something very light or doing for a very gentle walk and kind of building from there, kind of in relation to what you feel comfortable doing, that can sometimes be kind of a good achievement to kind of starting small. Journaling or tracking symptoms, writing down how you feel before and after exercise, identifying patterns, which we'll come back to that a bit later. When I have a present slide on about discussing with your cardiologist, you'll want to tell him how you're feeling when you're being active, how your symptoms are like, which will help better feed the advice that they give you around being exercise. Also, a body system is like going out with a friend or family member, someone to kind of encourage you to get out, be active, and also someone to just kind of have a chat with and kind of unwind a little bit in relation to some of the stress that you might be feeling. Speak to a mental health professional. There's talking therapies, which is it's kind of it's in England anyway. I'm pretty sure it's in the other nations. It's a kind of a service that you can kind of contact if you're feeling stress or anxiety about a particular thing. Also, the cardiomyopathy nurses are here for that as well. And then ultimately, education. Sometimes it can be a bit scary learning more. So that's why it's sometimes good to kind of speak with a health professional about educating yourself as well. Because sometimes if you Google your condition, it can be a bit kind of overwhelming, some of the things you might see. So it'd be good to speak to someone um, in your care team about that, and attending webinars like this, joining a cardiomyopathy support group as well can help with that. Listening to other patients, how they've responding to kind of the diagnosis, how they're managing it can really help. And then just like some even affirmations that you might see kind of floating around, in the sense that instead of thinking like I'm fragile or I'm nervous, just saying I'm learning to move more safely and wisely, and going and shifting your focus from what I can't do to what I can still do and enjoy. Remember what we looked at easier in relation to changing your mindset. Instead of saying, "Oh, if I can't go back to what I used to do, then what's the point?" So we need to just make sure we kind of have confidence in what we're saying. In relation to what exercise is best for you, this isn't really there isn't really any answer here. It's just more individualized to you, your care, your interests, your hobbies, your past medical history. Um, some people like gardening, some people like dancing. So it's not necessarily that you should get back to going to the gym, you should get back to doing this or that. It's kind of what you did before and trying to get back to that. with kind of what modifications? Do you modify the intensity? Do you modify the duration? And if you didn't engage in exercise, can you engage in it now? And for the reasons that we spoke about in the previous slides, this is gets a lot of attention as well about steps. So we're trying to shift our focus here instead of trying to achieve a number, what we're trying to more focus on is maybe look at improving from where you are at the moment. So if you're doing like 2000 steps, so if you have a fitness tracker or a watch that tracks how many steps you're doing, and steps basically count from the moment you wake up to the moment you go to bed. So brushing your teeth, walking around the kitchen, all are counting steps, not necessarily when you're going out for a walk. So any movement throughout the day when you're not being sedentary will count as towards steps. So what are you doing at the moment? And can you just improve that slightly? With the steps and the improvements that we've seen in steps, it doesn't there isn't any kind of guideline saying that you need to walk fast, it needs to be brisk or anything like that. It's just literally accumulating steps. And we can see here that some research then was proposed that a 1000 step increment reduced 15% reduction in all-cause mortality. So an individual who was doing 3000 steps and increased it to 4000 steps, that was a big health benefit for them. And even people who've increased by 500 steps saw a reduction in their risk. And this isn't saying that you need to be walking briskly. It isn't saying you need to be walking outside. This is just more looking at reducing your sedentary time, less time sitting down. So even if you struggle a little bit with going for walks because of your breathing, or you've been told to reduce the intensity, doing a few steps doesn't involve intensity. So it's another angle that you can look at about moving forward. And then just some behavior change strategies about how we can kind of implement activity if it's not something that you do or that you want to try implement, or if it's not something you particularly enjoy. We can kind of hit SMART goals in relation to SMART means it's an acronym of specific, measurable, attainable, realistic, and time. So if you want to achieve a certain goal, what do you want to achieve, by what time frame, how are you going to achieve it, by how many days a week, for how long, etc. That going back to the FITT principle, the frequency, intensity, time, type that we spoke about in a previous slide. Using habit stacking just basically means where you're with an existing activity that you're already doing, that you add something to it. So, for example, after brushing your teeth, you might do some gentle stretches for a couple of minutes. This is something, since you paired it with something you're already doing, like brushing your teeth, you don't have to think too much about it. There's not too much stress around it. You don't have to kind of go out and kind of get changed or anything. So you're just, while the kettle is boiling, you might be doing some arm exercises, or you might be doing some kind of calf raises, etc. Um, that's what it means by kind of habit stacking. And then just pairing activity with a current habit is just kind of falling on with the same kind of thought process. Utilize accountability is where we were talking about earlier about bringing it, walking with a friend, or using family, or bringing them in with you, using joining cardiomyopathy support groups where you can kind of talk about your activity, see what you've done, kind of use that to support each other. And then just planning for obstacles. Another thing we see with cardiomyopathy patients is your recovery isn't linear. And what I mean by that is if you've engaged or start to engage into its current level of activity, you're not going to be getting better necessarily every day. There will be some ups and downs, maybe because of medications, maybe because of your symptoms. Sometimes you might be feeling a bit more tired, lethargic, you might be feeling a bit more stressed. So during those times, what can you do instead? If you normally went for a 15-minute walk, can you just go for a 5-minute walk instead and implement some kind of gentle exercises? If the weather is of an issue outside, if it's raining or if it's not particularly safe to go outside because of because of the weather conditions. Can you do some exercises in home instead of going for a walk? Um, and in relation to these change strategies, this is the idea of then when working with someone like myself, a clinical exercise physiologist, or going with cardiac rehab or speaking to your Cardiomyopathy UK nurses, you're trying to just talk about exercise, talk about being physically active. What does the next couple of weeks, couple of months, what does it look like for you? If you come up with some obstacles, discuss together how you can overcome those obstacles and how you can implement it in your lifestyle. So just a quick recap. We're about halfway through the slides. So we just looked at about exercise recommendations. We look about it's common to feel anxious and how can we overcome that potentially, and strategies how to adapt a new exercise regime. This is just a case study of a patient that was referred to me by their cardiologist. A 52-year-old with not really much of a past medical history, just asthma and GORD is just gastric reflux. He's initiating event was OOHCA, is it out of hospital cardiac arrest, which means that he was at home and he was found. His wife happened to be coming home and saw him, and then called the emergency services and started doing CPR on him. He had a downtime about of an hour. Um, After kind of further kind of investigations or diagnosis, he was determined to have arrhythmogenic cardiomyopathy. He had an ICD implanted. He had a good ejection fraction. If you don't know what that means, then it doesn't really matter. And he was asymptomatic, meaning he wasn't really, when he was doing walking, etc., he wasn't exhibiting any symptoms. But his cardiologist, due to his condition, restricted him, should I say, to 110 beats per minute. Um, and basically on that RPE scale that we looked at earlier, that 6 to 20, that means a very light activity. So he was advised to avoid an activity where he was getting a bit breathless. And this was extremely challenging for this particular patient, mainly because they were an ex-runner. They were doing 80 miles per week in relation to running, and they were a sub 3 hours marathon runner. So that was so this was a difficult for them because we talked about earlier about identity. This person identified running was their identity. So if you took that away from them, they felt a little bit lost with it. So there were expression of negative thoughts, kind of inability to run was having a real negative impact on him personally, and then also the wider family as well. So then he was referred to me to kind of work with in a more individual basis. So this is what I want to do now is show you how people like myself work with patients like yourself, cardiomyopathy patients, and how it's not always easy to ask saying, can I go running? Can I do swimming? Can I do that? So I want to show you a little bit behind the scenes a bit. So my first questions when referred a patient like this to the cardiologist, straight away I asked, what has the cardiologist recommended? He recommended 110 beats per minute, no higher than that. What was the reasons he said that? It was a relation to avoidance of a certain progression of activity. If it was because it was a progression of his symptoms, what symptoms were we looking out at? Are we looking out for the patient exhibiting symptoms of dizziness, breathlessness? How would we know if we're making the condition worse? So that's another thing I was asking. Um, in relation to the activity as well, how long can we exercise per week? Are we allowed to exercise 20 minutes a day, half an hour a day, an hour a day? This is a question I asked. In relation to strength training, are we allowed lift weights? If so, how much? How many sets? How many reps? So these are all the questions you have to ask your cardiologist instead of just saying, can I exercise? Can I go do this? Can I do that? You need to be more specific. And that's why working with someone like myself or kind of having discussions with your Cardiomyopathy UK nurses helps to digest all this information because it's a bit overwhelming and you don't know what to ask it. You don't know what to ask. But hopefully now you're kind of learning what you can ask. I also need to look at the recommendations for that particular condition. What is allowed for that? HCM, what I might do for a HCM patient, I may not do for an ARVC patient, or I may not do for a DCM patient. So if you have a cardiomyopathy and you know someone who also has a cardiomyopathy and they're doing X, Y, Z, you don't know the background of their condition. You don't know what cardiomyopathy they have, what their heart function is like. There's a lot of different parameters that would dictate the exercise prescription and what would allow one person to do more exercise than another person. So I needed to understand about that as well. And this is a behind the scenes as well. When I'm working with cardiomyopathy patients or any patient, I need to look at their age, their gender, their medical history. So are they diabetic? Have they got high blood pressure? What medications are they on? Is this Are they implementing exercise for the first time? Did they exercise previously? What's their functional status? Which means when they move, have they got any hip pain, knee pain, etc.? I need to do an exercise test on them. I need to understand their goals and motivations, what they want to achieve, what's their interest. They don't like doing this form of exercise, but they like doing a different type. They don't like exercising in their home. They prefer to be outdoors. Um, they prefer something to be one in person, or they prefer something to be online. And then just risk factors in that was kind of going back to medical history again, if they're having blood pressure, diabetes. And even with this information, there's no universal recommendation. So, for example, with this ARVC patient, what I did with him, which I'll show you in a moment, I may not do with another patient. All these factors will dictate what I do. Medications can blunt the heart rate response. So if you're on medications like a bisoprolol, a beta blocker, and you weren't on that before and you were tracking your heart rate, that may reduce your heart rate. I need to kind of provide you education on that and help you understand that. But I also need to consider that when we're exercising. And as in, for someone who's exercised before, their introduction to exercise will be easier because their movement in relation to doing some exercises, it's not new to them. It doesn't feel so alien to them. So it'll be easier integration. And as I said again, risk factors and comorbidities can modify what's safe. So if you have a cardiomyopathy but you're also diabetic, and if you're taking insulin, we need to know your insulin levels before you exercise, during exercise, and after exercise. For example, if you've got high blood pressure, um, should we alter the training? There's more research coming out now about different types of exercise that you should do if you have high blood pressure. So we need to factor in that. So this is why I wanted to present this slide, because I'm frequently asked, people ask me, can I do running? Can I do swimming? And I can't really answer that question unless I know you clinically. And when I say when I know you clinically, this is what I mean. These are the factors I have to review: your medical history, your discharge summary, have a conversation with your cardiologist before I can safely advise on what you can do. And these are the added challenges with this patient and other patients as well. You had a previous level of activity. You had the event or you've had the diagnosis. Now there's a drop in your fitness because you've been told to reduce it or stop it. So now an activity that you did before may have been a 30-minute walk. Now that 30-minute walk is a higher RPE, meaning a higher rate of perceived exertion. You're now finding that harder. Your heart rate's higher. So our first step is building you back towards potentially what you were doing before. That's our stage one, getting you back to your previous level of exercise, and then moving you forward. What I often see with patients though as well is on the right hand side, if they weren't really active before, because of this diagnosis, they're now more in tune with their body. They're now paying attention to their risk factors, their nutrition, alcohol, smoking. They're now paying more attention to exercise. So they're actually, in a way, becoming stronger as an individual because of this increased awareness and enhanced understanding of their body. going back to this as well, this is what I worked on with the client and what I was asking with the consultant. I had to prescribe exercise for the client based on these four categories. Cardiovascular exercise to the left. Um, he wasn't given a restriction on the volume. He was he was walking for around uh 10 miles a day. He was told he could walk that, but he was told not to go above 110 heartbeat or not to go over a light intensity. Strength training he was allowed to. He wasn't given restrictions there. Being physically active around the house, he wasn't given restrictions there. And being balance and flexibility, he wasn't given restrictions there. This is just for this particular patient, and I wouldn't necessarily advise this for other patients with cardiomyopathies and such, but this is where it comes in individualized. So we were given restrictions around the left, the cardiovascular exercise, so we had a lot to work with. So I'll go back to this slide in a moment. So we did some traditional cardiac rehab exercises. What that meant is he would go to a particular station and we do some cardiovascular exercise. Might be step ups, it might be doing some sit to stands, it might be doing some chest press with a band. We did that. We also did a functional movement assessment. So we did some kind of like some squatting movements, some lunges, some overhead squat to see how he moved, see if there's any imbalances in his muscles to help reduce kind of risk or injury down the line. We did TRX training, which is basically a thing called suspension training. We did core training, which is for working on stomach exercises, and we did resistance or weight exercises. So we we did explore a lot with this patient, and we did explore lots of different methods. But that was because of just kind of seeing what he liked and what he didn't like. He didn't really like the functional movement aspects, but he did like the TRX or the suspension training. This was a struggle with this patient in particular, mainly because the limitation we had is he wanted to exercise to a point where he felt out of breath. Because when he felt out of breath to himself, he felt he was doing good. But that's where the cardiologists restrict him. So it was a challenge kind of to change the mindset around that. Also, as well, there's a lot of data coming out now in relation to, sorry, a lot of development in relation to smartwatches. So when you're speaking with your cardiologist, can you use that information to help kind of facilitate a decision for them to say that you can do certain exercises? So going back to a previous slide, so heart rate monitoring, you can wear Garmin watches, you have Apple watches, they can track your heart rate during activity. You can present that heart rate data to your cardiologist saying, this is my heart rate data when I went for a walk. What do you think about this? Do you think it's good? Can I keep with this? Your rate of perceived exertion, telling the cardiologist or your kind of healthcare team, when I'm doing XY activity, I feel it light, I don't feel it challenging, therefore can I continue doing it? The exercise intensity and type, I want to go for example, swimming. I want to do 20 minutes a day, or sorry, 20 minutes twice a week. I find it light. I don't find it challenging. I don't, I'm not doing the activity to overexert myself either. I'm just doing it to be moving. So you have to feed in all this information to your team instead of just asking, can I do this? Can I do that? Which is a simple answer where they might say no. Also, recovery. When you're doing this activity, how do you feel after it? Do you notice any dizziness? Do you notice any symptoms? You need to talk about this with your team as well. Fueling status, saying that you're well hydrated if you're not on fluid restrictions, that you're not kind of sacrificing on food, that you're eating appropriately, that you're engaging in a warm up and cool down, and maybe that you're not exercising alone. When you kind of feed this back into the cardiologist or your healthcare team, they're in a better position to advise on exercise. And this was the patient journey. So he was from the top left to the bottom right. So he received a diagnosis. They were given medical restrictions. He This particular patient did engage in rehab, but felt bored doing group exercises. And then there was a frustration because there was a lack of conversation about what he wanted to achieve. There was a lack of that one-to-one discussion of listening to him and what he wanted to do. Then referred to myself for some specialist support. We created an individualized plan to suit him and his needs. We used RPE, we used heart rate watches, we used all this to feed back into the cardiologist to determine what we're doing. Is this okay or not? Do you think we can continue with this? Because ultimately, what my role is, I'm given the information from the cardiologist about restrictions or limitations, and I translate that into an exercise plan. What does that look like? Because sometimes people are given that information, take it easy, don't overexert yourself, which can mean they just stop doing it because they don't know what to do. And then ultimately, what you're trying to gain and what this patient was trying to gain is regaining confidence or a sense of self identity that they're still kind of moving forward with purpose. And then in relation to kind of like exercise resources, we'll talk a bit about phase 3 and phase 4. Your GP can refer you to community exercise programs. Sometimes they're like 12 weeks in duration. There might be in London, we're linked with a company called Everyone Active. You're referred to a 12-week program. It's not cardiac rehabilitation, it's not linked with the NHS. But they deal with people with medical conditions like heart conditions, hypertension, blood pressure, kind of osteoporosis, and you're on a kind of a program, or you meet with a trainer on a one-to-one basis, and they devise an exercise program to suit your needs. The NHS have lots of resources as well on strength training, cardio training, core exercises. There's community groups in relation to kind of community walking groups, etc. There's exercise websites, which is kind of the same as the British Heart Foundation on exercises that you could do at home, um, and which kind of feeds in with the NHS service as well. And then phase 3, which I'll move on to now. This is where I work in Imperial in London. I work in a cardiac rehabilitation program, and this is our program. And there's similarity in programs throughout the country, across the 4 nations, where you might have an initial assessment with in our team you have an initial assessment with an exercise specialist like myself, a nurse, a dietitian, and where applicable a psychologist, and we write a kind of individualized plan of how we think you should move forward in each of those disciplines from a nutrition point of view, exercise, kind of nursing, looking at how you're managing your medications, and in psychology, do you need any more for kind of further intervention there? And then you engage in an 8-week rehabilitation program. Some of you may have engaged in one. Some of you may not have heard of it because ultimately not everyone is entitled to engaging in one if you have a cardiomyopathy, because the funding may not allow it. Cardiac rehab is more tailored towards traditional cardiovascular disease. And when I say traditional cardiovascular disease, what I mean by there is when you have like stents, bypasses, when you have individuals have a heart attack and there's like a blockage in the arteries, which is due to kind of potential lifestyle behaviors. Whereas with a cardiomyopathy, lifestyle behaviors can help you recover from the condition, but lifestyle behaviors are not necessarily a triggering factor for it or a cause of the condition. So what not everyone's entitled or not everyone's discussed with cardiac rehab. And then going on again, what we educate a lot in this program is what I just spoke about, but also when you're being active, you learn to know what your body, kind of what works for your body, what doesn't. So if you're starting to feel abnormal discomfort or pain, you will learn to stop or reduce the activity. Dizziness, severe headaches, these are all things you shouldn't be exercising or stop exercising. I'm sure you know, but it's just something that I kind of needs to be pointed out. And in conclusion, then, kind of coming towards the end, we should be engaging in safe, tailored physical activity, and I've just explained why. We should set realistic goals, adapt exercise to your needs. For some individuals, it might be more the psychology of exercising rather than the exercise itself. They might be nervous about exercising, they might be worried about triggering something. That's where you would need to have conversations. Um, and then by engaging in groups like this, you're gaining more confidence or support to understand what's normal and what's acceptable, so you can move forward with more confidence. And then some key considerations. So we want to balance exercise prescription for, we want to modify the exercise prescription to suit your condition, because ultimately, if you're given a restriction around exercise, it doesn't necessarily mean that you can't be active in general. It just means that we need to look at you in a more individualized basis and tailor it a bit more. It should be a shared decision-making process. What that means is that you have someone like myself, you have your Cardiomyopathy UK nurses, you have your consultants. You're using us to kind of determine the best plan forward for you. And ultimately as well, unfortunately, because the research as well, healthcare professionals often lack confidence in providing exercise recommendations for cardiomyopathy patients. And this is really just due to the lack of high quality research, and the complexity of the conditions. So this is improving. So 10 years ago, as such, there was very limited research and strict limitations, particularly around um, like ARVC, HCM, DCM, but we're seeing a lot of development in HCM, hypertrophic cardiomyopathy. Um, 5 years ago, more interest in emerging of safety data. Today, there's a growing research base, there's more patient-centered advice, and hopefully going forward in the future, there's better guidelines, better integration into cardiac rehab. If you have a diagnosis, you're referred to a program automatically, as opposed to not being eligible for it potentially. And this is two papers that were published this year. The one on the left, high intensity exercise in patients with cardiomyopathy, hypertrophic cardiomyopathy, is a paper that I was involved in, and my name's on the kind of one of the authors. And that was something I did when I was working in St. George's. We had a group of HCM patients. We exercised them for 12 weeks, twice a week. We got them to a point of somewhat hard to hard in relation to the intensity. And we did a kind of before and post testing with the patients and looked at what modifications it did to their condition. Did it worsen their condition? Did it make it better? Such. We had no adverse events. And it was shown that for certain patients with hypertrophic cardiomyopathy, not all patients, that this was a potentially feasible form of training. So there is research evolving.